Excellent. Thank you so very much. And thank you to those attending. It's a great pleasure to join you here today. Thank you for taking the time out of your day to join us. So my name is Dr. Graham Bilborough. I'm a veterinarian. Hopefully you can hear me clearly. I've got a little bit of a sore throat, but hopefully you can hear me clearly. I'm a veterinarian, did a residency in critical patient care at the University of Cambridge in England. Stayed on to teach at the University of Cambridge for a few years. Worked at another diagnostics provider, IDEX. You might have heard of them. Worked at IDEX for 16 years, but I've been lucky enough to spend the last 4 years as the Director of Clinical Expertise at Antec Diagnostics. And I'm delighted to introduce my co-presenter for today, Dr. Christine Garrett. Over to you to introduce yourself, please, Christine.
Thank you, Graham. Similarly, very excited to join you guys today. My name is Christine Garrett. I'm also a veterinarian. I am originally from Alabama in the U.S. I currently live in Nashville, Tennessee, and serve Antec as a professional services veterinarian. And I also still do a bit of relief work on the side, too. So really enjoy my time in clinical practice and then getting to see everybody in the field as a professional services veterinarian for Antec as well. Yay. Let's go, Graham.
Excellent. Well, thank you, Dr. Garrett. We have a very curious title for our talk today, Maximizing the Minimum Database with In-House Diagnostics, and specifically, what's up with that reference interval? So I guess you've asked me to come and talk about reference intervals. So I assume everybody wants an hour of excruciating detail on statistical methodologies employed to delineate population reference intervals. We're going to cover advanced inferential approaches, robust modeling techniques. I should admit that I'm going to cover in just too much detail, quantile regression, bootstrap resampling, Bayesian inference, and how those analyses provide precise estimation of the central tendency and variability. Well, I'm guessing not everybody's with me. Perhaps we're not here, Dr. Garrett, for a lecture on statistics. Instead, Dr. Garrett, what are we here to do, please?
Well, if this is the case, I'm certainly ill-prepared, so I may be in the wrong talk. But I was thinking we might discuss reference intervals and their utility in early detection and disease, more specifically, like the pros and cons of different types of reference intervals, like population-based, stratified, and individualized. We're going to talk about how age and breed affect the reference interval interpretation, and we're going to talk about the maximizing the value of the minimum database. May I suggest we go with my plan?
Okay. So you're asking me to go easy on the statistics today and to focus on the clinical value. So our topic for today, to reiterate, is how we get maximum clinical value from the minimum database. And what we mean by the minimum database is the chemistry, CBC, and urinalysis. We're thinking about in-hospital analyzers, so we're going to focus our attention on those. But we really want to, without going deep on the statistics, we want to understand how to get the best out of these analyzers so we can do the best for our patients. How do you like that plan, Christine?
Yes, please. Much more well prepared for this plan. Let's go with it.
Excellent.
As far as our disclosures, Graham and I are both happily employed by Antec, and Antec is part of Mars Science and Diagnostics.
Excellent. Thank you. So we're all here to do the best for our patients. Also, we're lucky enough to have some very committed and motivated pet owners interested in investing time and money in their pet. We want to be confident in how we interpret that minimum database, that MDB. And as we'll learn today, we're often going to see highs and lows on those reports that may be normal for that individual patient, that individual dog or cat. But how do we get the most out of our investment in diagnostic information?
I think we're also going to talk about how, or rather should, we apply these stratified reference intervals to our patients in the future.
Excellent. We're also going to look briefly at genetic health profiles, in particular the Antec's Wisdom profile. We'll look at an example of how we can use these profiles to better understand the breed of the patient we're dealing with, but also understand how it might affect our patient care plans.
And lastly on our list, I'd love to talk about blood work, but specifically the importance of baseline blood work. Individualized patient blood work and baselines give us a feel of what's normal for an individual patient, and we're able to better detect over time these changes and catch disease early during wellness assessments, while additionally allowing us to better interpret which values are out of whack in a sick patient case.
Excellent. So I think I could summarize our next hour together as a presentation on how to understand reference intervals, including specifically their limitations, so we can get the very best out of diagnostics. Now, when I eventually come to rule all of Antec, when I come to be the big boss of Antec,
we're not ready for that.
So Christine thinks the world's not ready for me to be the ruler of all Antech. I think it's only 3 promotions away and I'll be in charge of all Antech. And when I do so, the very first thing when I get this power of being in charge of Antech is I'm going to do away with the speed bars. I'm going to remove them from our report. And what do I mean by the speed bars? Well, there we are. I'm sure you've all seen them. I know some of you use different lab providers in the past, but they're on the right-hand side of the report. It's the same with IDEX as it is with Antech. We see these speed bars, which are a visual depiction of the reference interval. Now, the reason why I'm going to get rid of them, and which I'm sure will be incredibly unpopular, but I want to get rid of them because it's all too tempting. I catch myself doing this, that I just look for the marker that represents the result. It's all too tempting to see, is it in the green zone, as they are in the report we see in front of us, or are they above or below, in which case they become red or blue, depending what side they are. It's all too easy just to glance at those and decide, is it in the green zone or is it outside it? Is it in the reference interval or is it outside the reference? It's all too tempting to not think about the reference interval and just look for abnormalities. Instead, we should recognize it's not the fault of these speed bars, these visual depictions of the reference interval. Instead, it's about us being a little bit lazy. I'm guilty of this too, being a little bit lazy and not looking to see where those markers are on the continuum. Is the marker close to the upper limit of the reference interval? Is it close to the lower limit of the reference interval? We need to understand, are they transitioning from within the reference interval to outside of the reference interval? And indeed, where are they positioned in detail beyond that? We're going to see a few of those speed bars in today's talk, but instead we're going to focus a lot more on graphs. So we saw the speed bars in the previous slide. That is a snapshot in time. I have a much stronger preference of working with graphs with multiple measures over time. And as you'll see throughout today's talk, reference intervals have severe limitations that we're going to address today. A graph is a much better way of getting a fulsome story of a pet's life. So instead of speed bars, which are a snapshot in time, we use graphs for a fulsome story over the years of a pet's life. So in this talk today, we're going to look at several graphs as we look at patients together. Oftentimes, you'll see the analyte at the top left. I've circled it there. In this case, it's hemoglobin, HGB, but it'll be other analytes as we go through the talk today. We've got time on the vertical axis. Just keep an eye out, because sometimes I put the date going from left to right, and sometimes I put the date going from right to left. Depending upon your lab provider, there's usually a little button you can click on to say whether you want time going in that direction or in that direction. But in this case, we've got the most recent blood test on the left side. The green area on this graph, we're going to look at lots of graphs today, represents the reference interval. What I love about this graph is I can immediately see for what's happening with this patient. Now, we don't know this clinical case. You can't tie it to the clinical details because I haven't given them to you yet. But I can see the changes in this patient as we follow that graph, and I can associate it with what's happening with the patient. This is why graphs are so much more valuable than looking at those speed bars. Now, before we get into our first patient is going to be with Dr. Garrett and KitKat, but before we get into our first patient, just to remind ourselves how we think about reference intervals in the context of whether we're thinking about investigation, whether we're thinking about preventive care. I mentioned at the start, I did a residency in critical patient care, and I think back to my days, or perhaps I should say nights, working in emergency medicine. In that situation, we were often dealing with an emergent problem. So any changes in blood values were usually pretty dramatic. So I would have the cat that would come into my intensive care unit, have a creatinine of around 4 milligrams per deciliter. That's 350 micromoles per liter for those using SI units. Urine specific gravity of 1010, creatinine of 4, urine specific gravity of 1010. I don't really pause to consider whether the upper limit of the creatinine reference interval on your in-hospital analyzer should be 1.4 milligrams per deciliter or 1.6 milligrams per deciliter. For those in SI units, that's about 120 or 140. That fine detail of the upper limit of the reference interval was in no way a concern to me, because I had this obvious change in the blood parameter. So on the right-hand side of the screen, when we think about investigation, I would say reference intervals are supportive. As we investigate the problems, we're seeing more dramatic changes in blood tests. Do they match the clinical signs in my patients or not? The reference intervals are supportive to what's going on, but perhaps not so crucial that they're exactly right. Now, contrast that with preventive care, with our cat there on the left. Here, by definition, because we're dealing with preventive care, there are no obvious clinical signs in the cat. let's say this cat has a creatinine of 1.5 milligrams per deciliter. What do I do with that? Where the reference interval is exactly placed feels a whole lot more important. If it's 1.4 or 1.6, I need to be very careful because that could dramatically change my interpretation. So for preventive care, subtle to no clinical signs. And if we're going to only get one set of blood test results, having the best possible reference interval is likely a whole lot more important. And Christine's going to give us an example of what that looks like with a patient called Kit Kat. Over to you, Christine.
Thank you, Graham. You set me up perfectly. So in this particular case with Kit Kat, we have a wellness appointment. So it's just as Graham was saying, no clinical signs, right? This is a well patient visit. This is 2024. Kit Kat's coming in and she's had some routine lab work. So 10-year-old female spayed, domestic short hair, no clinical concerns other than that she's a little bit fractious. And we've all dealt with our fractious kitty cats in the clinic. She's had a stable weight since adulthood. And we can see on her lab work here, on her CBC, that her white blood cells are on the lower limit of normal. So let's look more closely at her differential. Graham, if you'll click off to the next slide for me. Perfect. So breaking down the whole white blood cell count into our neutrophils, lymphocytes, monocytes, eosinophils, and basophils, we can see that there's a neutropenia. So we've got that highlighted for us. This case also has a blood film review to confirm these changes. That's always a great resource too. If we see an abnormality on a CBC, we have the opportunity to create what we'll call a blood film, not a blood smear. Graham strongly prefers the term blood film. We don't want to smear those cells. But this, should this finding elicit like a big diagnostic plan? We can certainly create one for Kit Kat to work up this neutropenia, but I would ask everyone to think about asking the question in the clinic, what do we want to know from this case? And for me, I like to ask, do we have any historical blood work for comparison or trending? And fortunately for Kit Kat, we do actually. So this lab work is from 2016. Remember, we were at 2024, so we have lab work from several years prior. And do we feel any differently about pursuing a workup in Kit Kat if we know that this cat CBC 8 years ago, when we were a bit less fractious and angry in the clinic, it also showed neutropenia? So this type of case has to bring up the in-clinic scenario where we may hear that there's no reason or indication to do historical blood work on a patient. Like, why would we even do this? My pet's totally fine. And I think the client who says that that patient has been healthy and there are no concerns at home, I need to offer an alternate perspective for them. So how do we shift that conversation and consider that this historic baseline in health can aid us in the interpretation of data, both in illness and in wellness? So when I see that the neutrophils have been low for over 8 years, it makes it more difficult to say, let's check this in 10 to 14 days. So maybe we don't necessarily need to do that recheck because I know it's not going to change. However, I also look at my differentials for neutropenia, which might broadly include things like a bacterial infection, atypical infections, toxin or drug exposures to induce that neutropenia, or maybe bone marrow disease. And then, of course, we got to keep immune-mediated neutropenia on our list as well. Or that last one, that idiopathic or spurious finding, making neutropenia, this cat's normal. So Kit Kat could be totally fine, but maybe we need to look at that historical information. And maybe Kit Kat's just angry and she's telling me to back off. This is my normal.
So that's a great point that Christine makes there with Kit Kat. Kit Kat, we're looking there at those speed bars on the right-hand side of the screen. Those are population-based reference intervals. Kit Kat is an individual, and as we're going to see recurringly today, population-based reference intervals do not always serve the individual patient. So that brings us to the big problem today. The thing that we need to talk about the problem with reference intervals. Now, I know you likely know this already. After all, we appreciate that reference intervals, we can see results outside of the reference intervals that can be normal for that patient, just as we did with Kit Kat. We can see results within the reference interval that are abnormal for that patient. Further, we know that abnormal change for an individual can be lost within that reference interval. So it starts at a low point within the reference interval. It moves dramatically, but it's still there within the reference intervals. Reference intervals serve the population. They do not always serve the individual well. We also know that different breeds can have different normals. Take the giant breeds like this terrier that we see on the left, we might expect a very different set of blood test results, normals, if you forgive the inverted commas, than we would for its much smaller parts like the miniature Danes. On top of that, we appreciate differences in age, sex, neutering status. We appreciate that the reference intervals we apply to our patients are for a very, very broad population of a given species. Again,
can't wait to see a miniature Dane in practice. I can't wait to see
miniature Danes. They're a pretty rare breed of dog, but in England we saw a lot of these giant terriers and miniature Danes. Again, reference intervals are likely better called population reference intervals, noting that they serve the population and not the individual. Now, to solve this problem we have with these population reference intervals there on the left, we try to think about having something called stratified reference intervals and personalized reference intervals. So stratified reference intervals, they're probably new to you. Personalized reference intervals, they're probably new to you. You're very familiar with population-based reference intervals because that's what you see there on your printout from your lab report today. So let's start by thinking about stratified reference intervals. So stratified reference intervals is a set of reference values that are established by dividing a population into specific subgroups that have certain characteristics. It could be age, it could be sex, it could be breed, it could be any other demographic or physiological factor that you might be interested in. For example, you might want to have a pediatric reference interval. That's a stratified reference interval because we're looking at one particular strata, pediatrics. You likely already know that we have different expectations for pediatrics. We have different expectation for ALKP activity. We have different expectation for hemoglobin in these juvenile animals or pediatric animals compared to adults. And we could divide up that population a myriad ways. Now, a third option, and you'll guess that this comes from human medicine, a third option is the so-called personalized reference intervals. These are a set of reference values tailored to that individual's unique biological profile. So on the left, we have the population, smaller group with stratified, and then down to the individual with personalized reference intervals. Now, personalized is a term that comes from human medicine, where we're dealing with people. And so I tend to prefer individualized rather than personalized. Know that in the literature, it's often referred to as personalized, but my patients tend not to be persons. They tend to be dogs and cats, in fact, exclusively, and not people. So I prefer the term individualized, but if you're looking in the literature, it's usually referred to as personalized reference intervals. Whatever we're doing with these reference intervals, the ambition is always to have so-called tighter reference intervals, offering more sensitive tools to help detect pathological status. Now, this is such an important concept for today. I'm going to reiterate it with a quote from human medicine, somebody called Professor Chris Whitty. I know him from my days in England, but to quote him, if I may, population-based reference intervals provide a general benchmark for clinical measurements. Important words there, general benchmark. Nothing more significant than that. But their limitations lie in failing to account for individual variability or specific subgroup characteristics. Meanwhile, stratified and personalized reference intervals consider factors like age, ethnicity, gender, and offer a more accurate and relevant diagnostic insight. So that's the plan. Let's see how well this concept from human medicine works in veterinary medicine. So let's take a look at this example from veterinary medicine. This is a paper by Hegsted, Davis, and others from 2015, and they were looking at thyroid function. We're going to look at a few markers here, but I'll try and avoid getting into the detail. Just concentrate, please, on the principle. So we're dealing here with T4 on this particular table. I've circled it on the top layer. Don't worry about the units of measure. I'm going to provide both SI and conventional or old-fashioned units. I don't want you to look at the numbers. I just want you to look at the spread of numbers. So each row is a different breed of dog. You may see a lot of these breeds. You may see none of these breeds in your hospital, but we see collies, English setters, golden retrievers. We look at the two columns on the right, the lower limit of the reference interval and upper limit of the reference interval, LRL and URL respectively. So those two columns, those reflect the population reference interval. Ignore the numbers in brackets, just concentrate on the numbers in front. And I guess the point that I want you to take is that for one breed of dog, and it doesn't really matter which one, we see a lower limit of the reference interval should be set at around 0.34. And another breed of dog, if you do the study, should be set at 1.16. And this is a real challenge for clinicians. Antec or IDEX or whichever lab you give is going to give you a population-based reference interval with a lower limit of probably 0.8 in micrograms per deciliter. But we can see from this study that had we done the reference intervals by breed of dog, we would have got dramatically different numbers. Again, don't remember the details because it's impossible to remember the details. It all gets very complex. And I guess, Dr. Garrett, tell me how you deal with this in a clinical environment.
Sure. I think this is a piece where some clinical experience can come into play, and based on the knowledge of a patient's, like, their signalment, right, including their breed, if it's known, we actually have an idea about what that patient is. What can I expect? But more importantly, what does my physical exam tell me, and how do I integrate this objective information, these objective details from my diagnostics into what I know about a case and additional resources that I might need to pull from or reach for? And I think we're going to get into that a little bit more today too.
We are. Thank you, Christine. So to understand why breed-specific reference intervals don't serve us as veterinarians, we need to step back and consider, how do we determine reference intervals? Now, I promised earlier I wouldn't get deep into the statistics, and we're not going to do that. I promise you today, we're not going to get too detailed on the statistics. But for those of you using in-hospital analyzers, likely coming from one of the companies like Antec or IDEX, we need to understand how those reference intervals are created and how they may or may not serve the Asia veterinary diagnostics area as well as we might hope. So for those US-based companies like IDEX and Antec, I've worked for them both, so I'm confident I know what's happened. They follow a set of guidelines from the American Society of Veterinary Clinical Pathology. When they're determining these reference intervals, they look for 120 or more healthy dogs or cats. These dogs or cats are determined to be healthy by examination by a veterinarian and some blood tests, but these are all based upon pets that are conveniently available to the veterinarians like me working for these companies. And you can assume they're US-based populations, and we'll get to why that's important in a second. They find a population of healthy-looking dogs or cats, they get some blood samples, they run some tests, and then they build some descriptive statistics to describe the results from those patients they deem to be normal. And this little fella at the bottom of the screen, this little dog, is woofing to remind us that healthy dogs can be outside of the curly bracket. They can be outside of the descriptive statistical ranges that we describe. Now, as we do this, we do demographic matching. What I mean by that is I try to find a population of dogs that represents the dogs that are seen here in North America. So I make sure there's lots of Labradors. We see lots of Labradors here. I make sure there are some Greyhounds, not too many. I make sure there's some Boxers. I make sure there are some Boston Terriers and the like. I suspect already you're spotting the huge problem that we face is that the breed mix of dogs that Graham finds here in Maine when doing this kind of study, I live in Maine, I should say, Maine in the northeast coast of the United States, is very different from what you might expect to find in Singapore or Hong Kong. Bluntly, it's also problematic here in the United States because the breed populations that we see, the breed mix that we see in New York, is very different from what we might see in Texas. It isn't a US versus Asia thing. When we're putting together the mix of breeds in these reference interval studies, it depends upon what dogs are convenient to Graham. And I guess the one take-home message is they may not work well for the dogs that you happen to see in your hospital. Same is true at IDEX as it is at Antec. Now, I promise not to go deep into the statistics, and I'm not going to break that promise. But as I get these group of healthy dogs, I plot them out on a graph on the horizontal axis. I've got concentration for whatever blood test I'm interested in. I have the number of dogs on the vertical axis. And in theory, we're always going to get a normal, if you will, Gaussian distribution, that famous bell-shaped curve. Doesn't always happen, but for the sake of today's conversation, we'll assume it does. And I draw my lines on this graph to include 95% of the normal population, accepting that the tails of this distribution, I'm sure you've seen this concept before, accepting the tails of this distribution, there are going to be some normal dogs that are not included within the range. Okay, now that all sounded very theoretical. I'm going to show you how reference intervals are created. Same was done at IDEX, this is done at Antec. I'm going to show you how those reference intervals are done. Again, not going deep into the stats, just want you to get an appreciation of how these things are done so you can understand that all reference intervals must come with some skepticism. So I use some software called EP Evaluator. It doesn't really matter what the software is, but EP Evaluator is the software that I used. And I was in this case looking at monocytes. If you look at the top right of the report, you'll see that it's monocytes. And in this particular study, I had about 950, you can see the red box there, had about 950 dogs. This is a huge, by veterinary standards, this is a huge reference interval study. This is a reference interval study. For those of you that have the Antec hematology analyzers, you'll have the output of this study on your analyzers. Very big study done in this particular case. So we had 950 dogs. Now remember, all of these dogs were deemed to be healthy by the veterinarians examining them. Again, I'm not here to go into the statistics, but I want you to look at that bell-shaped curve. Well, the first thing you notice is it's not a bell-shaped curve. Don't worry, we've got statistical approaches that we can use to address that. But as you look at that bell-shaped curve towards the right where I've put that red arrow, I guess the question I always find myself asking is, are dogs with a monocyte count about 1.2, are they really healthy? Are we really sure these dogs are healthy? The veterinarians examining them said they were. I could leave these dogs in my statistical analysis, or I could take them out. That is a choice that I as a human make. And I guess the one thing I want you to take from this graph is not the stats, but there's a human, someone such as me, that makes a decision. Do I leave this dog in the study? Do I take it out? Do I really think that dog's healthy and representative of a healthy population? So again, not here to go into the stats, but appreciate that there's human opinion that changes whether a dog's in or a cat's in or out of this study. And that underlies why you might see very different reference intervals for your in-hospital analyzers than you might do for the reference lab. And we're going to come back to that topic a little bit later, but just appreciate that there's a lot of variety in there. So
this is like a compass for navigation, not a definitive GPS, Graham.
Exactly right. Great interruption. Thank you, Kristen. Yes, you're absolutely right. Just take it as a compass. It's going to point you in the right direction. It is not an exact GPS. So we've mentioned this before. It's a formidable challenge to get the reference interval study population right. I should probably say appropriate. It's a formidable challenge. And again, we're not going to go into the details of the stats too much, but I want you to look across the screen. We've met this principle before, that breed mix within the study matters. And so you're probably familiar with box and whisker plots. The box within each of these represents that the middle 50% of the population. The whiskers at the end of these box and whisker plots represents the extreme, well, I think it's that in this particular case, it's that 97.5 percentile. So we can capture 97.5% of the population. We've got our population here described well with the red dot representing the median. Again, don't get into the details here, but just appreciate how different the distribution of results is for the Chihuahua than it is for the boxer. So when Graham's building his reference interval studies, it matters how many boxers are in there, how many Chihuahuas are in there. And it's all done, I'm afraid, at the convenience of whoever's doing the study. So I often get asked the question, why does my in-hospital analyzer have different reference intervals than the reference lab? And there's multiple possible reasons. Often with in-hospital analyzer reference interval studies, we're using fresh samples to reflect an immediate analysis versus age sample, the time taken to get the sample to the reference lab. We're often using different analytical methodologies, but in large part, it comes down to the study populations are often different from one reference interval study to another. So that is why, frustratingly, reference intervals are often different between your in-hospital lab and your reference lab. And I'm going to give you one last example. We're not going to dwell on this for too long, but we're going to think about those reference intervals that we see on dry slide chemistry analyzers. Now, I've been around veterinary diagnostics for a long time, and I remember an analyzer called the Kodak Ectochem. For those of you that have used the vet test in the past, you'll recognize this box. Perhaps looks very similar to the vet test. This analyzer has exactly the same slides in it as were used in the vet test, later the Catalyst. Very similar to the slides that are used in the Antec DCX and DC5X. These dry slides have been around since the 80s, and some of the reference intervals have been with us since the 90s. Now, the reason why that's important is that the reference intervals haven't changed over the decades, but the population probably has. So the reference interval studies were done back in the 90s. Back in those days, we think about the different breeds of dogs that we would see. So the original studies done back at Glasgow Vet School in the UK in the 90s, we questioned how many Boston Terriers were included in the study. None. zero. In Glasgow in the 90s in Scotland, you did not see Boston Terriers walking around the streets of Glasgow. Stark contrast to the situation today where Boston Terriers have become incredibly fashionable. The take-home message is the technology, the slides may be the same from the 90s, but the population of dogs that they're serving has changed considerably. Christine, welcome back. You disappeared for a second, which caused some panic, but welcome back.
I'm here. Thank you so much.
At the end of all that discussion, I guess the take-home message that I want you to understand is that population reference intervals are highly problematic. We're going to give you a better solution as we get to the end of the presentation. Population reference intervals, as Christine said so well, they're a compass. They're not precise GPS, not surprise sat-nav, as we prefer sat-nav to GPS. They're highly problematic. And so you might be questioning yourself, well, would stratified reference intervals be better? Graham, you mentioned those earlier. Would stratified reference intervals be better? Well, let's take a look at human medicine, where they wanted to build stratified reference intervals for creatinine. Take-home message, to spoil it up front, is that stratified reference intervals are also problematic. So this is a study from human medicine, where knowing that serum creatinine is influenced by muscle mass, they had the expectation that men needed to have a higher creatinine reference interval, generally having more muscle mass than women. Further, they said as a healthy older human, you tend to have less muscle mass than your healthy younger self. So they expected to find creatinine reference intervals were lower for healthy older adults. And these are the histograms they found. The labeling's a little bit confusing, and so I've added some of my own. Creatinine is on the horizontal axis this time. Population percentage is on the vertical axis this time. And I've added letters to the legend because they're a little bit confusing. As expected, I'll give you just the abbreviated version. As expected, distributions for women, A and B, are to the left of men, C and D. That makes sense. That's what they expected. But by contrast, and unexpectedly, higher creatinine concentrations were found in apparently healthy older populations than younger patients. So B, older women, was to the right of A, and D, older men, was to the right of C. Now, this was an unexpected finding for the group because they thought they'd found healthy men and women. The challenge was when they dug a little bit deeper, when they investigated a little bit further, they actually found out that these humans in their 70s, it's pretty hard to find people in their 70s and 80s with normal kidney function. They deemed them to be healthy before going into the study, but the reality was, as we'd expect, unfortunately for people in their 70s and 80s, they were not perfectly healthy. Now, this may sound esoteric, this may sound strange, but when we think about our cat equivalent, I'm often asked, well, Graham, why don't you have a reference interval for geriatric cats and creatinine? I would turn around and say, you find me 120 healthy cats that are geriatric that have perfectly normal kidney function, because they're just not out there. So stratified reference intervals seem like a good idea, but when it comes to practice, they're actually incredibly hard to do. They have a theoretical benefit, but they don't often bring the value. But Christine, over to you to tell us a little bit more about how we think about breed. Sure. And how it comes to interpretation.
So when it comes to breed, I think about rounds and how we always start rounds with our signalment, breed being one of those things that I would lead with. So when we think about breed, it might help remind us of specific abnormalities on that minimum database that we've referenced that have no consequence, or maybe abnormalities in the absence of clinical disease that could have consequences. So think about the Labradors that Graham's mentioned earlier. Those Labradors may have an increased ALT. That's something that we can expect or see with those particular breeds. Similarly, like a Scottish Terrier with an increased ALP, or maybe a miniature Schnauzer with idiopathic hyperlipidemia. So just some examples of things that we might run into. And then also there are diseases that are more common in a breed that we're looking at that are not evident on a minimum database that could have a significant consequence. So looking at this breed and thinking about, am I expecting, or is it more possible or likely to see something like a hemophilia or von Willebrand's factor deficiencies or MDR1s? So taking those things into consideration as well. Graham, if you'll flip to the next slide for me. I think we've all seen tables like this one at CE events like this or in textbooks where we can be really tempted to start taking screenshots. So no one do that. These are not our take-home messages, but it's really not necessary to take screenshots of these things because arguably knowledge of these hematologic abnormalities that are more prevalent in a particular breed and knowing where to find that resource is probably a more prudent way to go about this. So if we're looking at some historical lab work for a breed, for example, like does my miniature schnauzer show evidence of this Grim, you know how hard this word is to say, stomatocytosis.
Stomatocytosis.
Yes. So click for me, we'll highlight that one for our audience, which of course we should all remember that stomatocytosis is a disorder of red blood cells, where those cells may become stomatocytes or cup-shaped with a little slit-like mouth or central pallor instead of that normal round zone. And we can associate that with that abnormal membrane with changes in ion permeability in that membrane and sometimes hemolytic anemia. But if we don't want to remember all of that, we, of course, have the internet for this exact reason. So you don't have to screenshot this list. We have the internet. We have these resources. And I think that's really important to take into consideration when we're thinking about breed-specific abnormalities. What do we need to remember? What's important? And what resources can we call upon when we run into these things, looking at our minimum databases, when we're thinking about signalments and consulting with cases. So how do we apply this knowledge when we look at our reference intervals, Graham? Like, does this support the use of a stratified reference interval or maybe something different?
Excellent. Well, we started, to give you a brief recap, we started and we described the problems with the population-based reference intervals. We're now looking at stratified reference intervals. And again, you're going to find in some ways they're problematic. Now, the most common question I always get is, Graham, why don't we have a stratified reference intervals for greyhounds? Now, I spent some brief time in Singapore and I didn't see a single greyhound, but I'm going to mention them because they're always in the textbook, and I adore greyhounds. They're such fun creatures. But the reason why we're thinking about them in the purposes of stratified reference intervals is you could almost question, are they really a dog? Are they really Canis lupus familiaris? They don't seem like a dog. They seem like something quite distinct from the dog. And so there's general agreement that we recognize higher values for red blood cells, hematocrit, and lower values for white blood cells and platelets. This breed of dogs, the greyhound, is a prime candidate for its own set of reference intervals. Dr. Garrett, can you show us how this works in practice?
Oh, for sure. And we are going to have just a couple of quick references from some studies that are breed specific to the greyhound. And we can see in this one in particular that greyhounds do have, in fact, that a lower white cell count, their neutrophils, eosinophils, monocytes, lower platelet counts, a higher hematocrit, hemoglobin, MCVs. While we don't want to dive into the nitty-gritty of all the stats today, this study did also show differences between like male and female, and it's not just the CBC. So we have other studies too that now that Graham has familiarized us with our box and whisker plots, thank you so much, we can take into account some of our chemistry parameters as well in these kind of evaluations. So this study looked at SDMA in greyhounds and non-sight hounds and found that yes, in fact, greyhounds do have a higher mean SDMA concentration. So looking at about 13.1 compared to that control group of our non-sight hounds at about 10.2. And I promise I'll make this all relevant with the case in a moment. But this finding is a normal biological variation, an example of what greyhounds may benefit from, why they might benefit from a different reference interval compared to those non-sight hounds. So as a clinician, let's take a look at Josie. I think it's always important to look at a case example. So she's a 7-year-old female spayed greyhound. So we have our signalment and we have our CBC here. So hopefully everyone can see these little bitty numbers. But what are the rules about greyhound CBCs again? So let's review those for just a second. Higher values for red blood cell counts, the hemoglobin, the hematocrit, and those MCVs, and then lower values for their white blood cell counts like neutrophils and lower platelet counts. So if we look at this particular case with Sweet Josie, how do we do? Is any of this true? when we look at those individual numbers, where do they fall on their visual reference interval too? Looking at even those speed bars that Graham so adamantly dislikes. I think that we can use this information to say that Josie kind of follows the parameters. She's following the general trend, but she's not actually going outside of some of those reference intervals. And then we have her a couple of her chemistry parameters as well, so her renal markers. They're also variable in greyhounds. So recall that greyhounds have higher values in creatinine, BUN, SDMA, among others, and they tend to have lower values for phosphorus. So let's look at it again. How did Josie do? Did she have anything flag as abnormal? High or low? Not necessarily, but we can look at our speed bars and get an idea about where we're trending here. So for this population-based reference interval that we're using for those speed bars, we need to take into account where Josie is. And ideally, I'd bring into something that we bring us back to something we talked about earlier with, do I have previous lab work? Is there something I can compare to? But since we don't have that for Josie, why don't we look at another case example too? Similar to greyhounds, dachshunds have reported higher hematocrits, about 52% rather than 50%. And higher hemoglobin concentrations of about 180. If we can click off to the next one, Graham, too. So hemoglobin concentrations being around 180 rather than 160s. And then for our red cell counts, we have those two for you on our graph here. If you can click, Graham, and about 7.7 rather than 7.2. So all these numbers, but let's look at Colin. Colin is the dachshund in the photo in the basket. He belongs to our director of consultation services, Dr. Mitchell. And let's look at his lab work to see if he fits into this dachshund basket that we've made for him. So I can say that yes, based on his CBC, we can look at his hematocrit and the hemoglobin. He's following those dachshund parameters that we would think would be more appropriate for maybe his breed. But no, not so much for that red blood cell count. So maybe Colin's broken. Dr. Mitchell would be devastated. Is Colin a broken dachshund? Maybe this breed-specific reference interval also has some pitfalls, though. So, Graham, can you give me another option? What else do we have?
Oh. Yes, we have some other options. So we've said it already. Population-based reference intervals do not serve the individual. Breed-specific reference intervals, whilst attractive, have a number of limitations, and we'll review some of those, and then we'll get to something hopefully a little bit better. So Josie and Colin demonstrated stratifying by breed could help, but the dogs don't always, and the cats don't always follow the rules. We need something better than stratified reference intervals. But before we even think about that, I guess the question I always face is, do I even know what breed of dog I'm dealing with? And there's a fun little website you might like to try when you have an idle moment called Guess the Dog Breed. And there they have statistics for how well veterinarians do compared to breeders. And I'm afraid to say veterinarians don't do quite so well as you might have hoped. I always remember in the consulting room, I'd get the breed wrong. The challenge is, well, not just my lack of knowledge of dog breeds, but the challenge is that phenotypically, we can be confused as to what breed we're dealing with. And some of the time, it can be very misleading. Phenotypically, what the dog looks like is not necessarily reflective of the genes that's inside that patient. Now, we're running a little bit behind, so I'm not going to dwell on it too much, but I do just want to mention the possibility for using genetics to better understand the individual patient we're dealing with. And when I grew up in England, border collies were a very popular group of dogs. We didn't call it NDR1 medication sensitivity. That name hadn't been dreamt up, but we did think that collies were sensitive to ivermectin. We didn't know the details then. We're not here for a lesson on pharmacology, and we're a little behind, so I'm not going to dwell on it. But the point that I would like to make is in those days, we assumed if a dog had white feet, that it was related to a collie. And we assumed that if it was related to a collie, we shouldn't use ivermectin. And we used to have this wisdom, this tribal wisdom, if you will. If it has white feet, like the dog in the picture, then don't treat. This was taught to me. I can't stop saying the expression because it was so forced upon me as a veterinary student. White feet, likely to be collie related, shouldn't get ivermectin. Now, nowadays, we know about MDR1 medication. We don't have time to, MDR medication sensitivity. We're not going to get into the genetics of it today. We recognize there's a number of pharmaceutical agents that could be effective. But what I want you to appreciate is when you're doing panels like Wisdom, and Wisdom's available through Antech Diagnostics, when we look to see if these dogs are genetically at risk for MDR1 medication sensitivity. And you look through the tables to see, this is obviously based on North American data. But the point to take home is that looking for white feet was a little ridiculous. This MDR1 medication sensitivity isn't well represented phenotypically. Looking at the breed isn't always helpful. And I would guess rather than trying to rely on the veterinarian to determine what the breed is, use of these genetic panels can help determine not just what the breed is. So Wisdom will provide you with the breed mix-up. You can see an example of a dog here that's had its Wisdom panel. You'll appreciate it doesn't look like it should have MDR1 medication sensitivity, but it did. And the only way to tell sometimes is by doing these genetic health profiles. We obviously also have the breed mix there. So stratifying by breed is problematic. Determining what the breed is problematic. So people then turn to me and say, well, Graham, why don't we just stratify by age instead? You've already said that puppies and kittens are physiologically different from adults. Why don't we have a puppy and a kitten reference interval for use on my NTech analyzers? Well, the challenge is how we're going to bucket, how we're going to group those different ages, because a kitten doesn't suddenly become an adult, a puppy doesn't suddenly become an adult. It's a gradual process. So it's a nonsense really to think about a set of pediatric reference intervals or a set of juvenile reference intervals based upon a certain number of months or a certain number of weeks, because there is no way to cleanly define meaningful age brackets because individuals age at different rates. Whilst we have a limited sample size in pediatric and geriatric groups, so the power to generate robust age-specific reference intervals based upon stratification by age is often inadequate. And I guess this brings us to the question is, when do you establish wellness baselines? I've already said things change, and for safety, I like to make sure all of that growth and development is behind us. So I usually establish my wellness baselines around the age of 2 years of age. So we've been through all the problems with population-based reference intervals. We now come to individualized reference intervals, our last group. And here with individualized reference intervals, we're taking an individual dog's testing history, combining it with information from similar individuals to create a customized reference interval for that one dog, or I should say that one cat. That dog can then be compared to what's normal for him or herself. Now we're going to get into some stats because we can't avoid it in this conversation. But before we get into that stats, I just want you to know that this really is as simple as building a graph. Okay, we're going to get into some stats. We're going to try and get to a bit more of a nuanced level. But when we look at this hematocrit, and in this case, time's going from left to right, that green bar represents the reference interval. This, for me, is when I think about the individualized patients. The take-home message, if you don't want to listen to Graham talk anymore, the take-home message is follow the trend in the patient over the years. Almost regard those reference intervals as a compass, as Christine mentioned earlier. But look at this dog, and it's declining hematocrit as the years go by from left to right. We don't need, dare I say it, any statistics to work this up. We appreciate what's changing, and we appreciate we may have a clinical problem here. So we're going to have a little bit of a look at biological variation, analytical variation. It's important that we understand those, but really the bottom line is let's look at a graph because the graph gives us the answer. Over to you, please, Dr. Garrett.
The graphs give us the answer. I love that. So I think we're all convinced that like baseline blood work and screening for disease, and we need to understand what we're looking at when we're looking at a particular patient's data or trends. But let's look at that biological variation. Biological variation is going to refer to a natural fluctuation and a value around a set point that occurs in the absence of disease. So these are our well patients. And we can look at variation of an analyte, so an individual analyte for an individual patient, and between patients in a group. So if we're looking at between patients in a group, we're calling that inter-individual variation. And in the graph, we have 15 healthy cats. We love a graph. We've got these 15 cats. You can see cats on the horizontal axis, and then our albumin for our analyte is on our vertical axis. So looking at these 15 healthy cats, where albumin is being measured repeatedly, and each dot represents a single measurement. The reference interval is represented by that horizontal line in that gray area. So Graham, if you'll click for me, that'd be great. There we go. We'll highlight that reference interval. And we can see that albumin appears quite variable between these 15 individual cats. And we would say that there's higher inter-individual variation. However, now that we look at the points that are clustered in a given cat, so Graham, thank you so much, highlighting the patients, intra-individual variation in the albumin level in a single cat. So if you look at our purple arrow, like in this value in cat 2, it would be outside of the expected biological variation for this cat. And in this case, while the value is still within that population-based reference interval, so that gray box, it's not normal for this patient. So our take home here is that when the variation of an analyte is small in a given patient, but large between those patients, this is an example of like how albumin, an albumin-based population-based reference interval, we have that limited utility for that individualized patient. So Graham, let's look at perfect. Let's look at this in another manner where we can use our example of our 15 cats still and look at albumin and say that this analyte varies less in a given patient. So we've got that narrow index of individuality than between patients when there's a high index of individuality. So in cases of analytes with a high index of individuality, a population reference interval will fail to allow early detection of issues in wellness. In these cases, subject-based reference intervals would be helpful. Alternatively, analytes that show more variability in a given patient than between patients have a low index of individuality. So that right-hand graph, you can see how we have that low index of individuality there, allowing for those population-based reference intervals to be more useful. So we're seeing that distribution is a bit different. But Graham, how can we apply this idea of individuality to our interpretation of the diagnostics?
Excellent. So I'm going to give you an example. Thank you, Christine.
Yeah.
This is complex stats, this index of individuality. Normally, most of the audience disappears because it isn't a fun subject. Again, the reminder, look at the graph. The trend gives us the answer. Understand that some values bounce around more in an individual patient. Some tend not to. We're going to get a sense of where we can find that detail in a website in a second. But again, let's look at those graphs because they're really helpful. So a brief reminder, because the stats are complex. So what is a subject-based reference interval? Based upon repeated measurements of an individual's analyte over time to stabilize a personalized, or if you like, individualized reference interval. Unsurprisingly, in veterinary medicine, this almost never happens. It's just too expensive to be done. It must be collected in stable health. We focus on the individual's biological variation. We don't usually get a subject-based reference interval. I do want to introduce you to a concept called reference change value. Again, we're not going to go deep into the stats. Know that reference change values are calculated based upon all this fun statistical stuff. They're published, they're widely available. You need to know your analyzer, you need to know your patient, but they can give you a guidance on when we're looking at our graph and we're following the change, what is a meaningful change on that graph? And so you may care to note down this website, www.vetbiologicalvariation.org. There, these tables, they detail what the reference change value is. So what percentage change in a result from time A to time B is a meaningful change based upon the breed, based upon the analyzer, the method used, and so on and such forth. And I'll give you an example of why this is helpful for an individual patient. So a graph similar to the one Christine showed a second ago, and we've got creatinine this time on the vertical axis, this time in SI units. The numbers don't matter, just appreciate that each of those dots represents a measurement from that cat during health, and we can see the spread for those individual cats. You can see the grey bar again represents that the population-based reference interval, given the units in conventional units of measure for those that prefer that. I guess what we can see here already is that the population-based reference interval does not work for this population. You can see there's healthy cats that are continually outside of the reference interval. That population-based reference interval was presumably set with a different group of cats. So, but we can use the data, we're not going to get into the stats, but we can use the data from this kind of study to determine the reference change value. What's a meaningful change in the creatinine. So I'm going to ask you to imagine a healthy cat, not a cat on this graph. This is a healthy cat that comes into your hospital. Then have an imaginary cat. And we're going to say, that this cat's baseline in health, we're going to use SI units, this one is 88.4 micromoles per litre. I've got the conventional units for those that prefer it there. So that was the baseline in health. The cat was about 2 years old, got 88.4. Today, the cat comes into your hospital. It's about a year later, and so suddenly it's 123.8. And if you look at our reference interval, both those results are well within the reference interval. 88 and 124, they're both well within the reference interval. You might be tempted to ignore that, but based upon the study, we know we looked up on our table, we could see that the RCV for creatinine was 36.8 using this methodology and in this species. And so I know a change of 40% going from 88.4 to 124 is meaningful change for creatinine. Both results are within the reference interval, but I know it's a meaningful change for creatinine. I don't know what's caused that change in creatinine, but I know it's meaningful. I know this isn't by chance or very unlikely to be due to chance. I've used that patient's baseline to see that something has changed over time. So to conclude, I'm going to hand back to Christine in just a second, but the conclusions I would take from all of this is the patient's own baseline is superior to population-based or stratified reference intervals. You might ask me, Graham, give me more stratified reference intervals for my ANTAC analyzers. I'm probably going to say no. I'm probably going to say I'd rather we worked using the patient's own baseline. We know that the patient's own baseline reflects that individual's biology. We can use those reference change values. Remember the website we looked at where we can look those up and help determine when change in a result from time A to time B is meaningful. Graphs make this stuff a whole lot easier. So often when I walk into veterinary hospitals, they're holding a sheet of results and that's all they're looking at. They're looking at an individual set, a snapshot in time. It's the graphs that make this stuff easier on the clinicians. So I've made the case for trending the baseline. And as we start wrapping up here, Christine, we'd love to have baselines, but how do we explain the value to baselines so that the pet owners are willing to invest in them?
And this is a question that we run into every day, right? In clinic or as a PSV for Antec. How do we get a client, our pet parents, to buy into this idea of lab work and baseline lab work? And I think at the end of the day, we can understand this information as veterinarians, but we have to keep that pet owner's position in mind as well. So how do we carry this message? How do we carry it through to them? And looking at the importance of this individualized patient data. Simply put, owners see their pets as unique. If we too can highlight their individuality, their little quirks, and understand that and translate this message of individualized diagnostics and interpretation for their specific pet into something exam room ready, I think we can really make a difference in the lives of pets. So getting this solid, robust baseline in health, it's going to help us identify outliers. So let's go back to Kit Kat, who appreciates me not doing a bone marrow aspirate or a core for that neutropenia, where my patient may have values that lie outside of the population reference interval, but still represent a healthy pet. That's their normal. And helping my client understand that that's what I'm looking for. I want to know their pet and their normal individually. Another example is it's also going to help us identify those potential breed-related oddities that are not clinically relevant, that may exist prior to illness, but we don't know about it, or we may be compelled to add them to our problem list or our differential list during disease, which will affect our differential, reprioritize things for us. So if we know what breed we have, what we're dealing with, and again, that patient, that individual composition, like with our wisdom panel, getting more information there, we'll know what's clinically relevant to our pets. And then, of course, helping with early detection. I think this idea of early detection is really crucial for our pet parents too. How can we find things earlier? And looking at analytes with that high index of individuality that are changing within population-based reference intervals beyond what's expected for a biological variation for that individual patient. So looking at things with a bit of a different lens these days, I think is a really good idea. But to wrap up our time together today, when you're talking about baselines from health, and we also need to consider more than just that minimum database and include that genetic testing, that wisdom panel information. And it can be done economically, and it can identify hidden problems that'll only be discovered otherwise sometimes with provocation, like surgery or drug administration. We'd like to know earlier. We want that early detection. But I hope you all have a better understanding of the methods behind the population and stratified reference intervals and the individual variations. I know Graham's statistics lesson has helped me quite a bit. I think you still got it in. But importantly, we should keep in mind the thought to look behind and beyond the reference intervals or those speed bars at what's possible within the reference value changes and the future of diagnostics, where we can integrate these baseline patient values and evaluations and trending, so graphs. So Graham loves a graph. We can incorporate this into our everyday practice. So with that, I just want to thank you all for the honor of your time and attention. And Graham is going to answer any questions that you may have.